Hey everybody, and welcome to episode 1 of No Referral Required. We're so glad that you're here joining us.
Episode 1!
Yay! Technically, we have episode 0.5, which if you have not listened to that, please go back and listen to that. We just kind of gave you some behind the scenes, introduced ourselves, told us kind of the why as to what we're doing. So just for a refresher, I'm Courtney.
Mandy.
And I'm Lara.
Yeah, and so we are 2 doctors and 1 non-doctor that are discussing all things behind the scenes of medicine, specifically with specialties that you maybe have always wondered, what is that? What do you do? What do you? Yeah, who are you? What do you know?
You made it up.
What are you going to do to me? Why would I go see you? Things like that. So that's kind of the goal of this podcast. So our first episode, we actually had somebody else planned, but then they had to reschedule. Yes, right.
Emergencies come up.
Yes. I mean, especially with doctors, we are finding out. I am finding out.
You got to roll with it.
They know, but it does make the most sense for our first episode to be interviewing you guys, Mandy and Lara. Because
once you said it, I was like, ding, ding, of course.
Because you are doctors in a specialty situation, like specialty. Yep. And it would just be really good for us to hear from you guys exactly why you're doing what you're doing, what you do, and how you got there, and things that maybe only a patient would know to ask. So that's part of why I'm here. Well, that's pretty much the only reason why I'm here is that
you're here for many reasons.
Is that I can be the patient side, because I do not, just as a refresher, do not have a degree in any kind of medicine. My degree is in child development, but it is, I've been through some medical things, and so I feel like as I was going through that, I kept getting learning a little bit of what I needed to ask. Right. And I hope that that is what I'm able to bring to the table, is things that either a listener who is also not medical would want to ask a doctor that is in that specialty, or something that they don't think they haven't thought yet to ask when they go in that situation. Because definitely when my first appointments, I'm like, yes, whatever you say, yes, which I do still say that, but I also am but let me ask this one question. I kind of have learned a little bit. When you go around the block a couple times, you know what to ask a doctor. Yeah. So
you got a crash course.
Yes.
In medicine.
Yes, I did. Somebody said, I'm basically an oncologist now. That's right. That's exactly right.
You're probably more up to date than many.
Well, maybe just because I was with very up to date oncologists. Yeah. So for all of us listening, remind us of your area of expertise, your job title, however you want to talk about it, your specialty.
All right, so this is Mandy talking, just so you can get used to hearing what I sound like. So Lara and I are both minimally invasive gynecologic surgeons. That's a mouthful. It is. We have forever been known as MIGS because it's just so many syllables.
MIGS, okay.
Yes, M-I-G-S. And just recently, the acronym changed because every now and then a specialty likes to throw a curveball at the general public and all the referring physicians and change their name. Okay. So you might also see it as complex benign gynecology. Or CBG, which I am forever trying not to say the acronym for marijuana.
But MIGS is a Russian missile.
Yeah,
so
that's true.
Yes. So my daughter's initials are MG, and some of her friends call her MIG.
Well, there you go.
So I'm like, that's funny. Okay, all right.
So the designation is just we take care of gynecologic problems. Surgically and medically. Okay. But when we do surgery, we try to do it in a minimally invasive fashion.
Okay. So that means
laparoscopy, robotics.
Yeah. Okay.
Vaginal surgery.
Okay.
Hysteroscopy.
Okay.
It's a fun thing. We get to put a camera in the uterus. It's very unique to our specialty. Nobody else does that.
Right.
You do the oophorectomy.
Oophorectomy.
That's me. I love that word. That's a new one I learned.
We do have a lot of O's in our words. So
yeah.
We get to own that.
It's a lot of funny names.
Minor in Latin.
Oh, there you go. Yes. Okay. So what training goes into doing what you guys do?
Yeah. So you go to medical school. That's 4 years. You do a residency in obstetrics and gynecology.
Do you have to major in anything in particular in med school, or is it or in undergrad? What is that? Start at
how do you get to med
question.
school?
How do there's not any not specialty wise, but as an undergraduate you need to do physics and chemistry and biology. Those are requirements for application, and you have to take the MCAT, which is a big long standardized test, and then submit your application. And that's just for medicine generally, for everybody. And then 4 years of medical school or DO school.
Yes, that's
Another
true.
path.
DO.
Oh, yes.
Yeah.
Say that. What is
So
that?
there's
yeah.
different kinds.
Oh, yeah,
There's
that's
different kinds
a
of medical
great
training.
segue.
We should get into that.
Yeah. So in the U.S., there are 2 medical degrees that come from 2 different types of school.
Okay.
The MD is what people are most familiar
Which
with.
stands for?
Medical doctor.
Okay, yes.
Allopathic.
Which is an
what we call it.
allopathic path.
Oh, geez.
Yes, right. The
I have to
allopathic.
write these down.
More
Holy
Latin.
cow.
And then the osteopathic
Okay,
path, which
okay.
is you get a DO when you graduate. That's your degree, your doctorate degree, which stands
Okay.
for Doctor of Osteopathy, or as we used to say, doctor begins with DO.
So are y'all DOs?
No, Laura's an MD.
I'm an MD.
Oh,
She's a DO.
and I'm a DO.
Oh, so you took 2 different paths to get to the same
Yeah,
ending?
pretty much. And they are so very similar.
Okay.
The DO schools philosophically have a more holistic focus.
Okay.
And they offer some things that are similar to what chiropractor type medicine is with manipulation of
Okay.
bones and joints and
Yes, so not as invasive.
muscle tension.
Possibly?
Right, yes.
Okay.
Which is funny that I
There's a
became a
theme.
surgeon.
Yeah, right? You went to cut people up.
It didn't work.
But at least I became a minimally invasive one. There
Yeah,
we go.
there you go.
Keeping on theme.
Kept with it.
So yes. So you can go either path. DOs are the minority by far. And they're sort of geographically situated where there are DO schools. So there are areas of the country where you hardly will see a DO. They're actually more in the military, actually. There's quite a few in the military. But from there, MDs and DOs can go to residency at allopathic institutions, or DOs can go to osteopathic residencies, which are actually few and far between and getting much less.
Okay.
But they both end up kind of at the same finish line,
Yes.
where you're board certified, even though they have separate certifying
Boards.
tests.
Yeah, okay.
Yes.
Sort of a different flavor, even though they're equivalent degrees.
Right.
Okay. So residency is how many years?
It varies. For obstetrics and gynecology, I know, of course.
Okay. For you.
obstetrics and
For us, 4.
gynecology, it's 4 years.
Okay. And
So
what are you doing while you're a resident? Everything?
You are doing it all. So
Okay.
you rotate, you work on labor and delivery, you deliver all the babies. A lot of residencies also have an emergency department rotation where you kind of learn how to treat emergent things. You also will rotate through gynecology and learn surgery and GYN issues.
When you're doing emergency, are you doing all, like, are you a general physician in the emergency room, or are you the person that they call when they're like, hey, there's a woman here that is having a baby and you need to come and save her life? You know,
Great
that
question.
kind of thing.
Yeah. When you, as a resident, if you're rotating through, you sort of act like the ED resident. The goal is for you to learn.
So you're Dr. Carter.
Yes.
But do they call you for all the women things?
Yes.
Absolutely.
Okay. Because they know you're interested in that? You've already declared
you're there,
it? Or,
and most people who are there are not interested
Yeah,
in, and
right.
so
It's just your rotation.
I picked up a chart once when I was on mine. It was like testicular torsion. I was like,
Yeah. Someone else knows more about this.
But a lot of other
Thought about that in a while.
specialties do have vagina amnesia.
Oh, they just
Where
choose
they
to forget.
Yes.
Selective.
Like, we
Selective
forgot.
vaginal amnesia.
Yes. So
Okay.
we are tag your it many times.
our
Okay.
favorite chief complaint presents to ED with vagina. So therefore, OBGYN.
Oh,
yeah, whatever. You have one, call OBGYN.
right. Okay.
Half the population, but that's fine.
Sure. Just forget about us. Okay. Okay. So 4 years of residency, and then after that,
After that, you can either be done and practice and be a general OBGYN.
Okay.
Do obstetrics and GYN surgery. A lot of people do both. But there are some additional pathways you can take if you're interested. There's actually many and growing different things that you can consider
Remember, we
doing.
talked about that doubling time last time,
Yes,
which actually
right.
got my facts wrong. And for medicine, it's 73 days. For the general knowledge, it's less than a week. But the current medical knowledge doubling time.
thank the Lord. That's
73 days.
That makes
Still
me
pretty
feel
quick.
a little better, though. I mean, I know it's quick,
General
but like,
world knowledge, less than a week. Medicine, 73 days. But
Okay.
still a lot.
Okay.
But yeah, that's how we get subspecialization.
Yeah.
So you guys took the route to go specialize in this
Yes.
particular area. That's when you made the choice?
Yes,
to
during
do it?
residency.
Okay,
So
yes.
you do a similar process to applying to residency. You fill out an application, you do an interview. When we did it, you did it in person. These days it's kind of on Zoom. And you are matched again.
Okay, this
So-
is a match day.
Yes, it's
Okay.
match day
Okay.
2.0.
Matches.
Oh, man.
So we do this weird thing in medicine where you put your list of programs where you would be willing to go, and then the programs put in a list of
people they
applicants
want.
they would be willing to have.
It's like a sorority. That's exactly
it's
very
much
sorority.
like that.
It goes into a black box. An external company has a proprietary algorithm.
You're
that
not
nobody
joking.
knows.
Okay, I
No,
thought
I'm
you were
not.
like bringing this joke home.
No.
Okay.
The computer
it's for real.
decides where you will live
The
and work.
computer
Wow.
decides,
Yeah.
and that's it. You move.
Holy
you go.
moly.
Yeah, so it's not like you get offers and you decide.
Choose.
Yeah,
you just
you
get
can't-
one.
You get
Right,
and
you
you
get
already
one.
said, yes, I'm going to do it.
Yes, by
Okay.
entering the
Yeah.
match.
Yeah.
Woo, okay.
So you only, list places where you're
You're really okay.
really okay with.
Yeah. So where did you each end up going at that point?
For fellowship?
Oh, so this is to get a
Yeah.
fellowship.
Yeah.
Yeah.
to get a
I mean, you
fellowship.
do it for residency as well.
Right,
Yeah.
right.
Yeah, so we did it twice.
Okay, yes.
Yes.
Yeah.
Thank goodness we didn't have to do it a third time.
So I matched at my first choice, which was
Oh.
at the Academic Medical Center where I
Where you now
currently
work.
work.
Okay, yes.
with Dr. Yunker. And
Oh,
that's how we
great.
met.
Oh.
She trained me, taught me everything I know.
I think I knew that, but that's funny. That's fun. Okay.
I matched at UNC
Okay.
for my
yes.
fellowship
Yes.
in Chapel Hill, which was my first choice
Okay.
for fellowship.
And how many years do you do the fellowship?
It was 2 years.
It's 2.
But they
Okay.
do offer it 3 in some places right now.
Okay.
But yes, most of them are 2-year fellowship.
Why would you want to do a 3 as opposed to 2?
Well, they'll add something like research year or a simulation training year where you can get a master's in education or something along those lines. So, some sort of
Add more letters.
extra feather
Yeah,
in your cap.
Okay.
Yes.
All right.
Yeah.
Especially if you're thinking of an academic career. It might
Right.
be
Yeah.
a path someone
Right.
would choose.
You need a credential like that. Okay. So after fellowship, then it's you get a job? Or?
Yeah. So this time
Okay.
you actually have to interview like a real person in the
Oh,
world,
yeah.
Yeah.
which you are not prepared for.
No,
Okay.
it's very scary.
To look at a contract and weigh
Okay.
those things. But
Yeah.
And you have made a lot of contacts, in your training, and you use those to sort of like, hey, will you talk to so and so at WashU?
Sure. Yes.
At UT Southwestern or whatever.
Right.
I'm
That's
interested
part
in
of the
moving there.
part of the appeal of going into continuing education in person is that you get to make lots
that's a
of
good point.
contacts, and then you still have those
Yes.
contacts
Yeah.
forever.
Know those
Right.
names.
Right.
Yeah.
Yeah.
But you learn also to not burn bridges.
Oh.
And
Small
to-
world.
Yeah.
Sure.
Okay. You're always auditioning.
How many times do you graduate? Like, how many times do you do some kind of ceremony where it's like, this is the end? Do you just do
Well, enough
like,
that my parents were like, we're not coming to anymore. And my sisters were like, really? Another one?
Right. What does this mean?
Let's see. Do we count high
College?
school?
Well, okay.
Yeah. I
So
mean,
you can
yeah.
start with
Okay.
your whole like professional, well, not professional, but yeah, higher education.
Yeah. So
College,
med
school,
school, fellowship,
residency,
residency,
fellowship.
So 4.
Okay.
Yeah.
But you graduate and you do the whole pomp and circumstance and all that stuff.
So it gets a little less high key each time.
A little more personalized
Yeah.
and
Med school
smaller
is the
groups of
white
people,
coat. No, you get
too.
your white coat pretty early in med school, right?
Yes, the
Like,
short one.
Short white coat.
the little
Oh.
Identifies
yes.
you as a learner.
A short. Oh,
It's a short
man.
coat.
Yes.
Yep.
That's funny. It's
a nice
and
way
then
of
a
shaming
longer
them.
one. Oh, he's got a short coat. I don't want him.
Hierarchy's
Okay.
alive and well.
So if a short coat walks
med
into
student.
my room
That's a
in the
med
emergency
student.
room, I need to be like, where's your long coat friend? Can you bring them along? Please go
friend.
find your
and then at some point you're so far down the path you quit wearing a coat.
Oh, sure.
You're just like, this is my
Yes,
I'm in my
this is
clothes.
who it is.
Yeah.
Or you come in from rounding in
Right.
street clothes.
Yeah.
Okay.
Although there was one rather famous attending at our institution who continued to wear the short coat his entire career.
Was he hiding?
Because
like,
he
please.
said he was a lifelong learner.
Oh, look at that. It's a
Eccentric.
symbol.
That sounds very.
He probably won
eccentric.
teaching awards every year for that.
Yeah.
That is funny. That's funny. So why did each of you choose to do what you did? Because you were obviously in your residency, you saw lots of facets of things. I'm sure you
Yeah.
delivered lots of babies.
Yeah.
Yes.
So many babies.
How many babies? Do you know?
600-ish, I think.
I think, yeah.
Sounds
I
right
think
for
we
you
got-
too.
Yeah,
Laura?
around in there. I
Okay.
think I ended up with close to, if you add C-section and
Yeah,
vaginal
yeah.
deliveries,
Yeah.
probably about 800.
Why did you not want to do
Obstetrics.
that? Like,
You can say it.
what
It's not a dirty
that did not? Well, I just wasn't sure which one it is. You know, why was that not appealing to you? And then what made what you're doing now interesting to you?
Obstetrics is a whole ball of wax.
Okay.
And, it's hard.
It's a ball of something.
It's a ball of something.
There's
a lot of balls that come out.
Lots of fluids.
Yeah. I would say, obstetrics is the reason for most people to go into OBGYN.
Sure.
Because it's amazing.
Yeah.
It's new life. It's fascinating.
It's the happy side, usually. Yes.
Right. Very happy. When it's not, it's very, very sad.
Yes.
But usually it's very happy. It's exciting. People who like adrenaline and energy and all of that.
A 2 a.m. phone call.
Yeah.
Come to the hospital.
Sure. You get to build relationships with patients, so that's nice. But I would say it is difficult to maintain an excellency in an obstetrics career and operate to the same level because it wins. It is like a magnet. And I feel that more and more over time as we watch the interplay between obstetrics and gynecology. I still love that they're together as a specialty, but it is on the horizon that they may not be at some point.
So you will either go to your OB.
You could, yes.
Or a
that's definitely
gynecologist.
in talks.
Okay.
I don't know if it'll ever change, but that's been
I bet there's a lot of
big
obstetricians
conversation
that
for a long time.
would prefer not to do surgery, and there's
Yes,
probably
there are, and
others
they
that
do.
are like,
And there's new
I
specialties.
don't ever not want to do surgery.
Yeah,
like,
and we have
I wanna
some
take care of the whole
in
patient.
the future, some podcasts guests coming up who will be able to speak to that, who have
Okay.
chosen that side of things,
Okay.
and one who's done both still.
Yeah.
So it'll be good to compare what
Okay.
we say to them. But I really wanted to be a good surgeon, and
So you felt drawn to the surgery
yes,
side.
totally.
Okay.
And I loved the gynecology. It's very much problem solving. And there's a lot of variety in gynecology, and it spans much larger lifespan than the obstetrics time frame. So you get to see different disease pathologies over time.
Yeah.
And I really like that. So the combination of the gynecology and the surgery is what did it for me.
Yeah. What about you, Laura?
Yeah, very similar. I still joke that there's nothing nicer than a nice normal vaginal delivery. Like it's an honor to be in that space. It's a lovely thing. But obstetrics is definitely the highest of the high and the lowest of the low. And I think what I slowly learned about myself over residency was it kind of depends on your personality too. There are some personalities that like settings like labor and delivery, like the emergency department, like the intensive care unit, where there are many, many things happening at once.
Sure.
And they like going from thing to thing and triaging and hitting the most acute or serious issue and then doing a quick flip and doing the next one.
Right.
And I think some people really thrive on that.
Sure.
And what I learned about myself over time is that I really love the flow state. I like to get into the OR where I have one problem, and it may be a big bad problem.
Yeah,
sure.
A lot of times they are big bad problems.
It's not simple, but
Right?
it's definitely
But
one.
but I love kind of getting that extreme
It's like
focus.
a deep
and,
versus wide situation.
yes,
Like
yes,
some people
and
like
really
to go
tunneling in.
wide and hit a lot of things, and some
Yeah.
people like to go deeper in
one thing. Right.
issue at a time. Maybe.
And I felt like that was just kind of my jam. It worked with my personality. It's where I became really drawn in and was fascinated and would think about, after my work day. And so over time, I just started to think, this is where I need to go.
Okay. That's great. I'm glad for people, especially surgeons who like to go deep. Joke. Okay. So as a surgeon, what is your day-to-day life like? Like, what does that look like? Week, maybe. Well, and I
that's
think
the nice thing about it.
Yes, from knowing you guys, like daily, but then also like a week at a glance. Like you're in clinic, you're in like how does that usually get organized for you? Do you do the arranging? Does someone else do the arranging? How does that look? What does that look like?
So we're going to speak from an academic standpoint, which is going to be a little bit different than maybe a private practice standpoint.
Okay, because that's where you practiced together.
Right.
So yes. And I will say that I'm no longer in academia. I moved actually to the VA, and I'll say right now that all of my thoughts and opinions have no reflection on the VA or the federal government and are solely my own.
Right.
But, and we can talk about that later, why I did that move in the height of my career from a fairly high leadership position at a somewhat prestigious academic medical center. And I have been totally fine with my decision. But, because I think burnout's important to talk about.
Yes.
But we won't talk about that right now.
Right.
So, but in academics, you are sort of allotted time for the things that you need to do.
Okay.
Based on what the institution needs from you. And you have to fit into their puzzle of all the other specialties that are there. So, all the other surgical specialties that you share the OR with. And then, your clinic and things like that.
Okay.
So you have less control, but you still have a good amount of variety.
Okay.
So, Laura, you want to talk about what your week looks like?
So my week, personally, I have 3 half days of clinic a week. So that's when you drive to the office, see your patients. A lot of them are consults. So they're coming in with a problem that someone thinks you can help solve. They're post-ops, so someone I've operated on that I'm checking in, or pre-op appointments where we've made a plan for surgery, and this is kind of the last time we're going to go through our list, talk about the consent form, talk about any questions they have. And then I have usually, we get cases sprinkled around, but usually at least one full day of OR. So that starts at 7:30, usually get there 6:30, 7-ish. You meet your patient, you do the consent form, you answer any final questions, and the operating rolls on. Those
How
are
many
usually
surgeries do you typically do in a day?
That's a great question. So it depends on the size. So what we call majors, generally a hysterectomy we book for around 3 hours.
Okay.
And then we might have smaller things like hysteroscopy. Our block time is 12 hours. So we could fill that with 12 hours. 12 hours is a lot for me.
It's a lot.
That's a lot.
It's a lot for anybody.
Surgery day.
I get pretty wiped. That. So
your
we
brain
don't always go there.
and your body.
But definitely. It's physical and mental. I think a lot of people don't realize that about surgery is how physical it is, because you're standing in one place, you're holding your arms in one place, you're moving patients.
Yeah.
You're doing a lot of pulling, especially with fibroids.
Yeah.
So it's pretty draining by the end. And then I have a day where I get to attend to my academic duties. So teaching. Running our fellowship program. So there are things that, just a lot of paperwork and grant things. I work on some grant projects at our university. So there's a lot of maintenance, emails, forms, documents, things you have to attend to, meetings.
So you said fellowship. So just making sure we keep like the thread going. So are you now in charge of choosing students to get to come and do fellowships with you all?
And I took that role over from Mandy.
So you look at a long list of people and you say,
when a group does it.
And you all decide these 10 or whatever the number is would be a great fit with us.
Yes.
Okay. And then you put them in the black box. Now you're on the other side. You're putting them in the black box
being on the other side.
Knowing the weight of what you're deciding, right?
Yes.
Like, that's a lot.
And we all say, once we review them, if I were interviewing right now, there's no way I would have matched.
Oh, yeah.
It's just the caliber goes up and up, and I'm always like, thank goodness I trained when I trained.
And they'll probably say that same thing when they're in your shoes, when they, go through all the things.
It's changed a lot, I think.
Okay, so a day is usually from 7 a.m. till...
when you're done.
Yeah, whenever you're done.
I mean, clinic's more predictable.
Yeah, clinic's more of a normal person's
like
schedule.
8 to
5:30.
Yeah.
Okay.
If you have a call night, that can be busy. Right now, we take home call on weeknights, so that's usually once every 1 to 2 weeks. And I'll take phone calls, talk to other physicians that want to transfer patients to our center, or come in if there's an emergency that needs surgery, needs some other kind of attention.
Okay.
And then some weekend call occasionally.
Yeah, okay. So how do patients get to you? Like how... Or do you want to talk about your situation?
No, I mean...
Okay, is it pretty similar?
No, my situation's not similar.
Very different now.
So you talk about... Okay, let's go back. You talk about that.
What my
that
day-to-day is like.
And
Well, our OR block ends at 3 p.m.
Oh, man. I can't even.
Which is one of the reasons I went there. There's no 12-hour exhaustion for me. Sorry, no. So what's that? 7:30 to 3, whatever that is. 7.5 hours, that's our block. And I routinely now have done this several times, finish around 2:15. So I know I love it. It's amazing.
I'm so happy for you.
And I don't take call. Which I also...
Like kicks to the gut right
Laura's, here goes Laura's and my friendship. It's over. Ladies and gentlemen, this is the end. We're just a funeral. So I take post-op call. I have to be available for my post-ops, but that's pretty much it. I don't take ER call anymore. And my clinic day also ends around 3 p.m. Sorry.
I love it.
I know,
I love it
sorry.
for
And
you.
I work 4 days a week. Yes. So I love it so much. But I still get to do what I love.
Yeah.
You know, and so it was a trade. You know, I understand. I knew it would be different working under the federal government, and that I was leaving really all my friends and my colleagues that I'd worked with for 15 years. And that was the hardest part. I missed them. So it was a choice, you know, for quality of life. But that's what my day-to-day is like.
Sure.
So it can be different. It just depends on where you work.
Okay.
But I also have no more upward mobility. Like I'm stagnant.
You're the top.
Or as I told the fellows the other day, I have petrified. Like a piece of wood.
They last the longest. It's all right.
Good point. Good point. Stability.
Get that pension.
Yes.
So, so that's what I gave up, you know.
Yeah.
And that's okay with me.
Okay.
All right. So what was your question?
How do patients get
How
to
do
you?
they get
Why
to
would I
us?
be referred to your office?
Well, mine's obviously all within the VA system.
Sure.
So I'm taking care of the veterans. But in other instances, they get referred multiple different ways.
Okay.
It kind of depends on how you set your practice up. If you want to be a consultant based on a referral only, you know, then you have to have a primary care doctor or a general OBGYN who doesn't do these types of procedures or take care of these complex medical problems send to you. And then other practices, the patient can just self-refer. You know, they can often look you up online.
Yeah.
There's a lot more of that, I feel like, recently.
They're Googling their problem. They're finding a list of doctors or,
Right.
you know, some mom groups on Facebook or something similar.
Sure.
And
Or
they
Reddit.
might,
Yeah.
Yeah,
and they
so
might
get a referral from a friend
Yes.
or of somebody online,
That
not
is very
necessarily
common.
from their primary care
Right.
or OB. Okay.
right.
Okay.
So some will have a gatekeeper, which
Yeah.
might be the primary care,
Yeah.
and some may not.
Okay. What's the most common thing that you treat?
Abnormal uterine bleeding, probably.
Yeah.
That's probably the number one
Okay.
diagnosis.
Before I
code
left,
for
it was
me.
endometriosis and pelvic pain.
Yeah.
And those are the top 3 of the specialty. Abnormal uterine bleeding, which would include fibroids,
Okay.
pelvic pain, and endometriosis
Yeah.
would be the most common reason to see a minimally invasive gynecologic surgeon.
Okay. And that's something that probably an OBGYN wouldn't they that's out of their
I think
typical
it's more of a matter of degree. A lot of times a person may have seen their routine OBGYN and tried kind of a frontline therapy.
Sure.
And if that's not effective, that's when they get referred.
Okay.
Or if they have a small and easily treatable anatomic problem that their primary OBGYN feels comfortable with, you know, they may handle that, but they send somebody with a 20-centimeter uterus to us.
Okay.
So we ended up getting kind of a selection of the more acute and
Complicated.
severe
Yeah.
and
Right.
complicated
Yeah. Okay.
cases of these things.
Okay. What's the scariest thing that you treat?
That's such a good question.
Mandy,
Thanks.
Mandy
I wrote
wrote
it.
it. Like, Mandy
It is
wrote
a
it.
good. It was very thoughtful. It made me reflect a lot.
Or the time.
Scary.
Yeah, I mean, it could be the most common, scariest thing
Yeah.
you treat, or it could be like a particular. I don't think you said that. No, like a particular case that you remember that like stayed with you.
Well, I think a lot about endometrial cancer because we were trying to rule that out a lot in our population with abnormal bleeding because it can present as abnormal bleeding. And I end up thinking about it a lot because the incidence is going up pretty significantly both in the U.S. and around the world. So we're anticipating seeing a lot more of these patients.
And endometrial cancer. Tell me, like, because I know ovarian cancer, uterine cancer. What is the other one?
So it's a
Cervix.
cancer of
And cervical cancer. Yes.
The
so what
lining
is,
of the uterus. So the lining is the glandular layer that grows with your menstrual cycle
Yes.
and kind of sheds
Yes.
when you have your period.
Right.
Those glandular cells can
Get out of
can
control.
change
Yeah.
and become cancerous. And it's actually the most common GYN malignancy. It's more common than cervical cancer.
Really?
It's more common, a lot more common than
ovarian
And there's
ovarian
no
cancer.
test for it.
There are some good tests for
Are
it.
there? Okay.
Better
Usually
than
for women's
ovarian
health, it's
cancer.
like,
I know,
no,
yeah.
sorry.
No, it's
There's
good.
nothing.
I would say
Good luck.
the pros of endometrial cancer. You can screen
Lots of
for
firsts.
it pretty
Yeah.
well.
Okay.
With a biopsy in the office. That's a very common way people do it.
Okay.
And if you catch it early, it's one of the more treatable diseases.
Is the treatment just to take it all out, like hysterectomy, or are we doing
Usually.
chemo, radiation, and all that stuff?
Depends on the stage
Okay.
and grade. So more
Okay.
severe cases will need
Okay.
chemo, possibly radiation too.
Oof, that sounds.
But very, very, very early cancer can be treated with just
just hysterectomy.
hysterectomy, which
Okay.
is nice.
Yeah.
But
I mean, with a grain of salt, it's really hard to have hysterectomy. It's not hard to have it.
You're right.
It's hard to live after.
We don't want to minimize
That's the hard
that.
part.
Yeah.
That's the hard part, really.
No, it's a fair point. But it's I think a lot of people haven't heard as much about endometrial cancer as some other types.
No, you said it, and I was like, wait.
Job educating the public on it.
I know.
And it's the most common GYN one.
But we think about it because abnormal uterine bleeding is in that umbrella of things that often get referred to our specialty. And that's the one symptom that's going to show up.
Okay.
And so that we're always sort of thinking about it and needing to rule it out.
Yes. So would you be paired with an oncologist at that point that specializes in that?
If we find it, we just refer to the oncologist.
Okay, and then they will say, yes, they need a hysterectomy, or we're going to do
Make
the
a
other
treatment plan.
bigger things. Right. Okay.
I would say the scariest thing for me isn't necessarily the procedure, but the medical complications that patients have, their comorbidities, and then they need a surgery that you really need to do. And they're very
give an
sick.
example. Give an example.
Primary pulmonary hypertension.
Okay.
Someone who is anemic but doesn't want blood products.
Oh, yeah.
Yeah. I mean, you feel very stuck. Someone with severe cardiac disease. We've operated on patients who had congenital anomalies, had very crazy cardiac surgeries as kids, and now they're on blood thinners.
And then you have to do surgery and put them under and all those risks that come with that.
So you're working very closely with anesthesia to make them safe. So those would be the more scary situations.
Okay. So it's the actual while you're doing the procedure that you're like,
well, in post-operative.
Okay. Yeah. I'm thinking of all the 50 things that could go wrong and trying
you want
to
be
think
quick,
ahead.
And you want to be bloodless if you can.
Oh,
as much as you can.
As much as you can. So you just want to be mindful of all the other systems that are affected when someone is under general anesthesia and you're doing surgery on them in their abdomen. It's not a black box. Surgery isn't, you don't go into a black box and then come out fixed on the other side.
Gotcha.
There's just so many factors.
You consult with all of those people before you do it. Yes. Do you often send a patient off, hey, I need you to go see a cardiologist and make sure that you're up to speed.
That's when clearance comes in. You'll hear us say, are you cleared? Did you get clearance for surgery? That's what that means.
Okay.
That they have a chronic comorbidity or diagnosis that could put them at increased risk, and so we have to make sure that the doctor that manages that particular diagnosis is comfortable enough, or it has at least done everything they can to lower the risk.
Optimize them.
Optimize
right.
them.
Go off your blood thinner for a week or whatever that looks like.
It kind of
sometimes
depends
if you
on
can.
it.
Things like that.
What's their echo? What's their all the other
okay.
Can they breathe okay?
Okay.
Are they smokers?
Do they have sleep apnea? Yes,
there we go.
Asked that question
all the things.
Lots of times.
Those I think are the scarier situations for me.
Okay.
Those are hard conversations. What is the risk of surgery here, and is it worth the risk that we're taking?
Right. Because everything. I think that's something that most people do not understand truly, and at least from now that I've again gone around the block, I know. But I think I thought either that like doctors / hospitals were this almost like a factory situation where it's I go in for a tune-up and it comes out all fine. You know what I mean? It was like and that was naivete and age, I was younger and things like that. But like, I just never, there is a risk with every single thing we do, with every vaccine you take, with every procedure you do medically, with every vitamin you take, with every, medicine or whatever, over the counter or not. I had like crazy stuff happening to me because I was taking Tylenol, and I was like, who knew that was the thing that my liver did not like at all? And that's just me personally. Like most people, pregnant women take Tylenol, but I think that's something that most people, unless they are at least in the medical field or have had a lot of medical procedures, understand that is a step that doctors are there to guide you through. Like, my risk of something really bad happening, what's the higher risk? Not doing something or doing it, right? And that's like the world you live in all the time. And I think I just thought there was like a book that you'd be like, okay, for this you do this, for this you do this, and this is exactly like a recipe. I know, like a recipe book or whatever.
Can I get it on Amazon?
Right. It would take less than 16 years of education.
Oh, yes,
no,
right.
but sometimes we have help. There's, we have an ethics service.
Okay.
So I've consulted them when I've had patients that either strongly desired a surgical procedure, but I had serious concerns about whether we should take that risk given, their medical problems or their beliefs around blood transfusion. It can be really hard. It's hard on you personally because you really struggle.
It's your call.
I want to give this person the service that they came to me for.
Right.
But
at the end of the day, the risk is on your shoulders.
Yes.
And it's not just them, it's their family. Something, you'll change their whole lives.
Right.
And
Lots
I think
of people.
you make a good point. I think it's hard to really feel sure sometimes that people understand the risk that they're taking. So services like our ethics team will talk with you, talk with the patient, kind of help provide a more neutral perspective and help give a framework to think about these decisions. But it can get really sticky.
Yeah. What's the weight of that emotionally?
In our specialty, if you look at the OBGYN as like a whole, there's a baby and part of this specialty, obstetrics. And so they kind of have to do things related to pregnancy.
Right.
So it's easier. And then there's people who treat gynecologic cancers, and they kind of have to treat.
Right.
So in those groups,
a little more cut and dry.
It's a little more cut and dry. You don't have another option.
Sure.
You have to deliver the baby.
Right.
You have to treat the cancer.
Yeah.
There's, for us, because it's elective and benign, you're weighing quality of life and risk.
Sure.
And you don't know the quality of life. You're not walking in the person's shoes.
Yeah.
So you're really trying to guess at that a little bit.
Sure.
Based on open-ended questions and sometimes things like lab values and like how many days of missed work, things like that are very subjective.
Right.
And that's harder.
Yeah.
Because you don't want to withhold a treatment, but you also inherently know more than the patient about what can happen.
Yes. I think there were several times where I was told by a surgeon that this would be the end result. And sometimes to the positive and sometimes to the negative. It didn't work that way. And it wasn't because they were not educated. It wasn't because they didn't do something properly or they didn't present me with all the facts. It was more just like they literally have not had the surgery. So they don't know. And every individual's response to a surgery is very different.
Oh, yes.
Like, rate of recovery. They were always like, you're going to be down for like 6 weeks. Like, you don't need to do anything. And I'm like, at a week, I'm like, I am so bored. I have to get up. I feel fine. I am fine. And so we discovered that is kind of a superpower that I particularly have, but like, I know that's not the same for most patients or for many patients.
Right.
And it's just really hard because you guys are looking at averages and you try to get to know the patient, but you have 15 minutes with them,
to learn their whole
to really know like what do they do? Yes, what's comfortable
what's
to
important
them?
to you?
Yes.
And what do they understand? What is their level of understanding?
Right. So it's a I can see where it would be a bit of a I don't want to say guessing game. That sounds really dangerous in a medical podcast, but just a judgment call. There's a lot. There's a big judgment calls that you all have to make.
It's not cut and dry.
Right.
Black
It's
and white.
not if A, then B. That's not the thing. How do people stay out of your office? Because it sounds like you handle a lot of problems.
They're men.
So how? That's the only way. You were waiting on that. That's funny. You were waiting on that question.
That is kind of
the only way.
But I'm done. That's call it a night.
That's
Tip your waitress.
All right. Any other? You're not going to expound. Okay.
This was a great question because it made me reflect how many things we treat that aren't lifestyle. The lifestyle is not as big a driver.
Right, like you have no control. Things you have no control over.
Yeah.
Even endo, fibroids.
Yeah. There's
you have no control.
Yeah. So there's no
good genes.
There's no I mean, your parents
of
making good choices when they met each other. Yeah.
I would say that so probably not for us is staying out of the office, but maybe coming sooner. Would be really the thing that people need to think about.
Okay. As a good thing.
Yes. Like to get ahead of something.
Sure.
Would you say?
Yeah.
To be kind of preventative, maybe.
Yeah, because some of these problems, if untreated, can really result in some pretty severe health impacts down the road.
Bigger changes in your lifestyle and things the longer you wait.
So the patient who's like, oh, I've just always bled like this my whole life. I thought it was normal. My mother bled like this. You know, you're like, well, you're running at a hemoglobin of 7 every day, which is not good.
Yeah.
No.
Yeah. Not good for not good for a lot of things.
So like assuming that things are normal when really they're very detrimental to your health.
Okay. So us being educated as patients and not being afraid to ask questions. Does it make you nervous when a patient starts asking you? What makes you nervous when patients start asking you questions? Is there any point in time like...
I love the questions. It's when the patient just sits and like gives nothing back. And I'm like,
I would agree.
Where are we with, do you understand?
Okay.
Am I reaching you?
Right.
Is there a need I'm not meeting? That's when I feel most flustered.
Okay, so you'd rather somebody being like, I Googled it and it said,
bring me your
blah,
list.
blah, blah.
I
So
said, bring me your list. Let's go through it.
Okay.
Because then I know where they are.
Right.
I know what they're worried about based on their questions.
What they
I know
ask,
what their fears are.
what they've
based on
searched.
their questions.
Yes. Okay.
You know.
That's a good point.
It helps me
So
learn
don't be
them.
embarrassed if you have Dr. Googled yourself. Don't be like, oh, that's going to be awkward because I'm going to go in and, say that I think it's this. And they're going to say, no, it's not, or whatever.
Well, as long as they're coming open-minded.
Yeah.
Okay.
That's the big thing.
I don't want to be told what to do.
Yeah.
I mean, I do like to know what someone prefers.
Sure.
And off the bat, like I'm here to talk about hysterectomy. All right, why?
Yes.
But also be open if I'm like, I don't think that's going to fix your problem.
Yeah.
Can we talk about why?
Right. Okay. How long a time do you think you spend on average with a patient with each new consult kind of thing?
Pretty exactly. You're very intimately acquainted with that data.
You know exactly?
Yeah. Well,
I mean, they only give you so much time.
They only give you. So I would say I get now an hour for a new and 30 minutes for a return, but that is not standard in academic practice.
Okay.
It's 30 minutes for a new and 15 for a return.
Okay.
So I get to spend a lot more time now.
Yeah. Do you often have a fellow with you when you do that? Are they coming with you?
I would say maybe 25% of the time I have a fellow with me. And so a lot of times the fellow will meet the patient first and take their history. Understand why are you here?
Yes.
What other medical journeys have you been on
that
are pertinent to this?
You here.
Right.
That we need to know, because the surgeons do not like to be surprised.
Okay.
So when you have a pre-op visit and the patient's like, oh, and I had been on this anticoagulant, you're like, what?
Yeah, right. What exact medicines did you take?
Yeah.
Yes, for sure.
No.
For sure.
So you get that important history, and then we'll make a plan together and go in and talk to the patient. And that's, we have 30 minutes to kind of get to know someone and make an initial plan.
Which
Plus do an exam.
No, still not. Yes,
and
right.
One of the things about OBGYN that no one really talks about and really wasn't factored in when they were like, oh, every specialty gets, this amount of time, is that we have you get undressed.
Yeah, right.
And then redressed.
Yes.
And I'm not going to talk to somebody with their clothes off.
Okay. That's nice. I appreciate that.
Because
I've been in that situation where you're like,
I just think that's disrespectful. Sorry if people are listening and do that. But they're probably doing it out of efficiency.
Yes.
They don't have a lot of time.
There's a lot of demands. But
I think, giving people a chance to talk, change, do their exam, change back, and then talk again takes time.
Yeah, right. Are you ever allowed, this is a question that I have, are you ever allowed to ask to not have a fellow?
This is such a good one.
Yeah.
I personally felt several times like, okay, well, I've never met you before, but here you're going to see all the things. All right, let's do that. Yeah. That sounds fun. You know what I mean? And it's often, I know sometimes women, especially with OBGYN or, gynecological things, they will pick a woman as a doctor, and then there may be a male fellow in there, and you're like, well, okay. I went to do a dermatology, the full body thing that you have to do once a year or whatever, and it was a female because that's who I had chosen. Yeah. And her male fellow that also came in the room, and I was like, well, okay, you're 12. You're 12. This is what a 42-year-old woman looks like. So sorry to disappoint you, but here it is. And it just can make it, especially if you're not. I know that doctors can do a little bit of a out of body situation when it comes to bodies. Like that's your that's
you make
your
it clinical
bread and butter, and so you don't think about it as being anything private or
nothing.
Nothing. Right, so is there ever a time when you can say am not?
You can always say that.
You can always ask.
But how could you say that would not be so rude to that other fellow? Because I'm like, I want you to be a good doctor, but maybe just not mine.
No, a lot of
on somebody else's.
Yes, you'll be so great. You will be so great with everybody else. But I just don't really care to let you see. Yeah.
You can always ask, and what we try to do is have our MAs when they're rooming the patient say, "Oh, Dr. Harvey has this fellow, this resident, this student," because we have a lot of learners.
Yes,
so our setting has what we call our tripartite mission, which is clinical care, research, and teaching. So they hold the clinical care, and they're equally important because we're contributing to society.
and to the
we're
future.
making new
Yes.
doctors.
Yes. No. Again.
Yeah. Oh, yeah. No, I hear
on
you.
a dream level, I'm like, this is
You
exactly
get it,
what
but
I
then
want.
it feels
but then when it's
different.
personal,
Yeah.
like, hello, David.
So-
I did not come to see you.
I know.
But good luck in your rounds or whatever. I don't know.
In your rounds. So you definitely can. So that's a great opportunity when you're talking with the MA.
Okay.
Just to say, I'd prefer not.
And it's not weird. They're not going to be like.
It helps a lot if you're also flexible, because what that means on my end is a change to my flow.
Yeah.
Yes.
Right.
Right.
So
So now I'm
Disrupting
slower.
your day. Yes.
Yeah, because I don't have someone helping.
Right.
So we try to accommodate those things, but it is helpful if you have flexibility or patience, willing to kind of work back with us on how.
Would it be better if I called ahead and
No.
said that?
Nah, it won't.
Nah.
They won't put it in my chart. Like, does not like
No.
male fellows. Okay. No.
And it's also harder to adhere to those things in an emergent setting or in the
Well,
OR.
I feel like emergency things go out
Just
the roof. Like,
different.
whatever, save my life. I
Whoever.
don't care. There's like
and
this
that's
whole.
a very healthy view, but
That's-
not
yes.
everyone
Not everybody
has
does that.
No,
Yeah.
I saw. I'm sorry, I'm probably going to talk about the pit just because that is our most recent medical thing. But there was this whole discussion because this EMT would not insert I don't even know, something, some medical something to keep someone alive because it meant she had to remove her bra. And she had a larger chest, and he was uncomfortable doing it. And, like, they make a whole big deal about women in the room. Would you rather have life or modesty? And all the women were like, life. And the EMT was like, noted. Okay. Like, he got it because I think sometimes, it does make people uncomfortable. But anyway. So, in emergency settings, I don't care. Whatever.
Yeah.
But, there were just a few times that I was like, this is a very
feels like
sensitive
a lot
area
coming.
of my body, and now there's a man doing it, you know?
Right.
I had a, what's it called? Oh, gosh, you just said the word, and I'm going to forget it. A procedure that I was totally not expecting. It was not, I didn't know there was going to be men doing it because everybody in that whole building I'd ever seen were women. And I was like, oh, this is like the women's area.
Yeah.
And then it was 2 men, and I was like, all right, nice to meet you. Okay, let's just do this. So, I mean, whatever. It's fine. I was just curious if you ever can do that. Okay.
Yeah.
You can.
Let's talk real quickly about social media, the internet, AI, all of these things. How do those things, how have they affected the practice in your span of working?
Oh, gosh.
Because you all have been working while everybody
Yes.
has been changing with social
Yeah.
media. Like, we all grew up with none, and
Right.
now it's every day, all the time.
Yep.
And just the internet in general. That did not exist
Right.
when you were in med school, I'm sure, right? Or very, very small.
Very small amounts.
ways.
Degree.
Yes.
Yeah, not especially for me. I'm a little bit older than Laura.
Right. So, like, how has that changed the practice in your particular practice of medicine
Let's
in
talk
your
about the
specialty?
positives first.
Yeah, I was just about to say it is truly a double-edged sword.
Yes.
Okay.
Like so many things.
Yeah.
Okay.
So as far as access to current information, chef's kiss.
Right. Yes.
I mean, the things that I can look up
Sure.
on my phone.
Yes.
Because you
From
cannot.
reputable,
Yes.
all the good journal, like,
reputable
all the things.
sources,
Yes.
right?
Uh-huh.
Because I cannot keep all of that in my brain, and I cannot read that number of journals
Right.
and keep up.
Right.
So to be able to provide current care with good evidence, it's much easier.
Okay.
Things like Up to Date, which is a resource that most physicians use,
Okay.
which is topic driven based on something that gives you the most current guidelines.
Okay.
Very accessible. I would say that as far as patient information, they're definitely more informed, but are they well informed
Sure.
or poorly informed?
Yeah.
Is the key. And it's hard to decipher, even for me, and I have a master's in clinical research.
Okay.
Which means I took 30-something hours on how to critically evaluate the literature and design a well-designed study and,
Okay.
and complete that in order to answer a clinical question.
Okay.
That is not the general population.
Sure. And there are lots of studies that are not done
And
that
let's
way.
put that in quotes.
Yeah.
Studies, research,
Yeah.
in quote.
Yeah.
And so while that's out there, the skills to evaluate that and separate the wheat from the chaff, if you will, is not common. And so
And it's not
that gets tricky.
It's not like a born with it skill. Like, you have to be
Right.
taught
Oh, right, yeah.
how to
Yes.
find source, source material, like how to original source material. Yeah, all the things. Yes.
Right.
Okay.
Yeah, I think I tell my patients all the time, there's good things out there and there's bad things out here.
I was going to say, do you ever correct them? Like, and teach them how to look for...
I do give them
okay,
sites.
I see. Oh, good. Oh, good.
Yeah.
That's good to know.
It's better to give them sites than to say, that's wrong, that's wrong.
Right. Don't listen to that
not
guy.
well received.
Yeah.
That could be their cousin, you know,
Right.
so I don't want to...
Yes. But you could say, this is how I always make sure that what I'm reading is...
And these are some trusted resources that are going to give you good information that's going to help you make a good decision.
And you want us to know good information. Yes?
Yeah, absolutely.
Okay.
I think I love that people are more informed, and I think that's been a real positive. People learn how to identify warning signs like postmenopausal bleeding needs to be evaluated. You know, those are ways that people can learn more about their own bodies.
And they've advocated for themselves. Menopause is a really great
like
example
the tide
of that.
is turning
Totally.
with that.
Yeah, so much
We're
out
talking
there.
about it now.
Yeah, which is
I don't ever
a good
remember
thing.
like my mom talking about it ever.
It's wonderful.
So they're definitely better advocates for themselves.
Okay.
Yeah, and people are finding communities of support in ways they couldn't do in a physical community.
That's good. Yeah.
You know, in the past, which also can be a double-edged sword.
Right.
Because great information can spread, but also misinformation.
Betty
can
Jo
spread
might not be your
wildfire
best source.
through those
That
groups too.
influencer might not be
Yeah, and then there's sort of a spectrum of a well-informed supportive group to an echo chamber. You know,
yes.
that starts
absolutely.
really dictating the way people think and feel. And there's been some great literature that's come out about how sometimes these groups can really send somebody down a rabbit hole. So it does run the gamut of good and bad.
Sure. Is AI a threat to this profession at all?
No.
On the day AI can use a speculum to die.
If the ER doc can't use a speculum, I'm not worried about AI.
Talking about people feeling comfortable in the office. When they feel comfortable with the robot doing their pelvic exam.
Man.
AI is helpful with the literature and, pulling things out on a theme search basis and, digging through good sources. So there's AI apps that are very helpful that I use.
Okay.
But as far as doing our job,
right.
I'm not really worried about that.
Right. Okay. That's good. That's good to know. What has changed? You talked about patients being more informed. I've heard you saying that. I've heard you saying that information is more accessible. What else has changed in your area of expertise in the last 20 years? Like, what's expected? Is there more or less expected of you? Is there, I don't know, like more people doing what you're doing or less people doing what you're doing? Like, how has that changed?
I would say the biggest change has been the differentiation, or that's a fancy medical term.
Is,
It costs $10 to say that.
Loans,
Essentially, what I mean by that is the creation or the evolution of more subspecialties out of the general OBGYN.
Okay.
So that you could pick ultrasound medicine, you could pick genetics, you could pick family planning, you could pick pediatric adolescent gynecology. So the evolution of more of those subspecialties where you could really get into a niche and that be the only thing that you take care of.
Okay.
That's definitely changed. But it's created experts.
I was going to say,
Because
how
that's
do you
what they
feel
do.
about that? How do you feel about that?
I mean, it's good and bad. It's great for someone who needs that expert. It's not great for places like rural communities.
That's what I was going to ask.
Yeah.
Who need general OBGYNs who can kind of do everything.
Right.
Because otherwise, those people are usually in cities. Those big experts.
Yes. Yes.
Yeah. And people get tired of being told you need to see 12 different.
Oh, yeah. I don't treat this.
doctors.
Go to this person.
Yeah.
I don't
Right.
treat
Yeah.
this.
Yes.
I think
that's
that's one of the
true.
downsides
That can get annoying.
of
That's
being
true.
an academic center. Is
Okay.
That does
you
tend to
have
happen.
so many specialties.
And you're like, who's
that
running
it's-
this ship? You
Yeah.
know? Who's in charge of all of
Why,
this?
when I go to my gynecologist, can I not get my birth control, my PAP, and talk about my bleeding?
Yes, right? You need
Seems
to go
like
to
that
two
should
other
be
different
right.
people. Yeah. Does it feel like you all have to be on your toes in terms of who you like? Some of the things you've just said, I didn't know there were doctors for that. How do you keep track of, there is a specialist that does blah, 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 certain issue. I know of that person. Is that a Google, like a search situation, internet situation, or do you feel like you have like a Rolodex in your head?
Word of mouth.
Yeah.
It's like the further you go, also the smaller the world gets, and you start to know.
So most academic centers, large ones, will try to have someone in those areas of specialty. And they're not all, I should say, they're not all board certified.
Okay.
So, and board certified means you take a separate boarding process. So while they all have some extra degree of training, fellowship, they don't all have to take another exam for that.
Okay.
They're just sort of noted to be specialists based on their training.
Okay.
But they're still obviously quite skilled in that.
Right.
So most academic centers will know of these, and they sort of populate their departments with them because that's how they draw in patients and become high-level tertiary referral care centers.
Yes.
But you could also go online to the board, you know, the orthopedics board or the OBGYN board or whatever, and they often list what subspecialties
are available
under the umbrella
of
their bigger specialty.
And then you could look for that kind of situation.
So if you're like, I wonder if anybody does. So ortho's definitely subspecialized.
Yeah.
Hand,
knee, right.
I only do hips.
Right.
Right. And so that's one that's very
like pointer fingers. Like, what do you get? How far down do we go?
Right.
In this list of things.
So you could go online and see what's available.
Okay. So that's
Google what you have.
Yes. Right. What's available? What's in my area?
Yeah.
Okay, if you could give patients one piece of advice as a new patient coming into your office, maybe they're a little nervous because, I mean, I think you're a little nervous because usually you have some kind of issue going on and it's a unknown area. As much as we are more enlightened, it's also very dark. It's also a very dark area, you know. There's not as much attention given on the
Gynecology.
lower half of a woman's body as there is the upper half. I mean, that's just the truth. So, medically speaking, what would the piece of advice be to a patient from a doctor's perspective?
That's such a good question. I tell my patients a lot, don't be afraid to get a second opinion. You know, it doesn't hurt our feelings. I get a lot of people who are seeking second opinions, especially for something that tends to be more of a quality of life issue. There's probably a lot of options available to you, and it's okay to seek a couple different opinions and thoughts on what your options could be.
Okay.
And none of us care. You know?
No. And if you did care, then you need to get over yourself.
Right. Yeah. So just, you know, I think a lot of people feel really hesitant to do that.
Sure.
But
my parents. There's I think it's a generational thing, honestly.
Yeah. Yes.
I think the older the generation you are, the less likely you are to disagree with your doctor. And I don't mean that in a disrespectful way. Just ask questions. Say, you know, who else could I talk to about this or whatever? So that's good.
But I think in this era of the multiple subspecialties, and there's just a lot more out there. It used to be hysterectomy was pretty much the answer to everything. There's a lot of stuff now that you can do besides hysterectomy for a lot of problems.
Okay.
And if you don't feel like you're gelling well with somebody, or you have further questions, or you just want to know if somebody else has a different thought process on it, that's totally fine to do.
Okay. Do you have a...
I would say that all those esoteric details you think aren't important might actually be. So feel free to tell me everything.
Okay.
Yeah.
Okay.
Because I can filter it.
Yeah.
You know what you're saying.
Right. That doesn't apply. This definitely
applies. And you might not think it's important, but it might be.
Right.
And so feel free to just share it all.
Right. Okay. All right. That's good. Okay, well, we've said that at the end we're going to do a speed round, or at least you wrote that in your notes. Speed rounds. Yeah. The joke. So I'll just ask you questions. And you can say yes or no, or like very short answers. That's what we're doing. So we're going to do that really quick. Okay? Ready?
Ready.
Unless there's anything you want to say like at the last. No? Good? Okay.
I'm good.
All right. Okay. Speed round. So are you superstitious?
Yes.
Oh.
Yes, I have been made so by my medical career.
Okay.
I wasn't before.
Okay.
Such a slap. I'm faith-based, and it's such a slap in the face. Because, you know, I'm like, yes, I put my trust in you, Lord, and you have total control. But I'm not going to say the Q word.
Yes, right? Okay. Is it only in when you're practicing medicine, or does it bleed out into other areas
it's
of your
just
life?
medicine.
Just medicine. Okay, that's the
Particularly
column.
call.
Yeah, it's just medicine.
Okay. Got it. Okay, which other specialty do you have to ask for the most help from? Like, who are you talking to?
Surgically, usually urology.
Urology. Okay. All right.
Starting to be colorectal surgery a lot.
Yeah. Medically, probably.
Our friends in the pelvis.
Our neighbors.
Medically, probably chronic pain.
Yeah, I would agree with that.
Okay. Yeah. How many hours per week do you work on average?
40. now.
Well, it's pretty variable. And it depends on if you count call, which I would count call.
I
had to change my life.
Yes.
So that's probably 60, 70.
Okay. So if you're thinking about doing this, remember 16 years of school.
You too can
work 70 hours a week. And I don't want to ask about college debt. I don't want to ask about that. But I don't want to ask about
selling
school
this
debt.
career.
What is there a word or a phrase that you end up saying multiple times a day as you work? Like, what's your common thing?
Scooch further down.
That's a good one.
That's funny.
I'd probably say, remember, you're the boss every time.
To yourself or to the
No,
patient?
to the patient.
Oh, like you're psyching yourself up in the mirror?
Yeah.
Remember, you're the boss.
You're the No, I think that
You keep that inside.
the public exam is such a scary thing for a lot of people. The way I try to, or a procedure. I do a lot of office procedures.
Right. Like you can say stop if you're
And
uncomfortable.
and I think
that's good.
I really can think a lot of pain is fear.
Oh, for sure.
And
100%.
if you can alleviate fear, you go 75% of the way of making a better experience for someone. So, and I think a lot of people's fear is that kind of loss of control.
Sure.
So what I'm trying to say is,
yes,
I will stop at any time.
Yeah.
You are in charge. You can tell me what we can do and can't do.
Okay.
So I try to give that control back.
Okay, that's great. Who in your inner work circle could you not live without?
Mandy.
But you are.
It's good to see each other some.
It is. We're still trying so hard. Right now, it's my clinic nurse. She's amazing. She does so many things, but it's very tight knit at the VA. You know, you're really
small group.
It's a small group. Yeah, it's me and 2 other people, and then our nurses. So she's integral in my day to day.
Yeah.
Yeah, absolutely.
Same.
Yeah, admins and our MAs.
Okay.
Get everything prepped for you. Lay the groundwork.
Right. Okay. Would you encourage your children to pursue a degree in medicine?
Oh, such a tough one.
I would.
You would?
Yeah, and I think because even though it's
Would
been
you
hard,
pay for it? Pay for it again.
Second level question.
Make my husband pay for it.
Okay, there you
We
go.
have separate checking accounts. So even though it's been hard, and I've heard people say I would never encourage my kids to do this. There's so much variety now, and you can really mold it. And I'm hoping that with this podcast, we show some of that.
Yeah.
You know, what different fields and what different jobs are like and how people have modified it to fit their life. That I think you can still have a very fulfilling life but do this. But there is nothing like medicine. There's nothing like taking care of someone and totally changing their quality of life for the better.
That's the rewarding part.
Yeah, totally.
Yeah, that's why you did it.
Yeah, that's a good question. I would never pressure them to go into medicine.
Sure.
But I think if one of them had, I think a lot of us feel kind of a calling. And I think you see that in people. I think if they truly had that.
To work 70 hours a week and spend all that time in school and all, I mean, yes, maybe you get a bigger paycheck, which is what everybody focuses on. But yes, I think it's absolutely a calling.
Yeah.
But I wouldn't want them to do it if it was
If they felt
just
obligated.
for the paycheck or if they felt pressure, if they felt familial or societal pressure.
Right.
Those aren't reasons that will last.
Okay.
In this career.
Okay, so we have one final question that we're going to ask everybody, but we asked you guys last week about if you could do anything else. Here's my question.
Oh, good.
Oh.
Outside of medicine, so again, we're humanizing you. It's one of our goals. Outside of medicine, what other topic could you discuss at length for an hour without any prep work?
Ooh.
Oh my gosh, what a great question.
That is a good question.
Anything.
Well, it's not TV shows.
Not up to speed on those.
Talk about it later.
Yes.
I am not an audiobook person that much.
Okay.
But
A study
I
just
started
came
listening
out.
to them in my car. Oh, tell me.
Because there's always been a debate. Is audiobooks reading?
Oh,
Because people are like, it's not reading. You're not doing it with your eyeballs. There's a study that came out that said the amount of things that you actually absorb between reading with your eyeballs and reading with your ears is the same.
Whoa.
But
so
isn't
it's
it
not.
with audiobooks?
Yeah, but you can
the
speed
part
it
that-
up.
I always listen at 1.5.
I listen to 1.2.
Yeah, sometimes
I don't want
to
it to sound like the
it
chipmunks.
depends on the author.
crazy.
Or the reader. It depends on the reader because sometimes readers are real slow and you're like, okay, we gotta go a lot faster.
We gotta pick it up a little.
But So
I like detective stories, like mysteries.
Ooh,
That's kind of
okay.
my thing. So if I find a good audio
I
one,
feel like you would like audiobooks if you like detectives.
Some of them I like. It depends a lot on the narrator.
Sure.
If they're
Oh,
not
for
good,
sure.
then I'm like,
Yeah.
forget it.
Nope. I'd rather hear my own voice.
We're going to have to, this is a topic we're going to circle back around on later.
Okay.
I'm going to see if you found an audiobook that you could tolerate.
Okay. There you go.
Stay tuned.
All right. Well, this has been so fun. Is there anything that we didn't touch on? You guys
No.
are going to be the interviewers, so,
I'm sure parts of our lives will pop up every now and then.
Lead in.
Yeah.
Yes.
But we're grateful for the opportunity to share.
Yeah, I'm glad that we got to listen to you. So,
It was a lot of fun.
all the things. So, thanks for being here.
Absolutely. Thank you.
Yeah.
Until next time.
Yeah. Thank you all for listening. And just make sure you're following us on Instagram. And we'll be back next time. Thanks.
Bye.
Bye.
This podcast is intended for informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views and opinions expressed by the host and guests are their own and do not constitute medical guidance for any individual case. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or health concerns. Never disregard professional medical advice or delay seeking it because of something you have heard on this podcast. By listening to this podcast, you acknowledge that the host, guests, and producers are not responsible for any decisions or actions you take based on the information discussed.